Assalamu alaikum. I feel very honored and humbled to be invited here, and thank you, Professor Shazia, for inviting me to speak on the topic. So, I will not only speak about the theranostic application of the three radionuclides just named, but I will also try to give you from within the industry of manufacturing radioisotopes experience how we can basically ensure and scale supply for nuclear medicine in the future. As I have to disclaim, of course, that I am an employee of Isotope Technologies Munich and dedicatedly in charge of the radionuclides. So basically, I will skip the agenda because we're already short on time. But you all know that when we look at the cultural nuclide chart, we have a really big abundance of radioisotopes available that are potentially interesting for nuclear medicine. But of course, once we apply some clinically relevant criteria to these radioisotopes, we will see that the number starts to dwindle. As we look at things like decay characteristics, the availability, but also the elemental properties in terms of radiolabeling chemistry, we'll see that only, well, not a small, but a handful of radionuclides will remain. And of course, if we look then further, we always have to ask ourselves, more specifically, what decay type do we have to have for therapy, for imaging? What is the half-life? Is it suitable for the purpose we need? And when we look at the availability, of course, we don't only want sufficient activities for clinical applications, but we want to have a routine supply, regular and stable and reliable for patient planning. So, and at that, of course, also free from any radioactive impurities in order to ensure the most safety for our personnel as well as the patients. So specifically, I want to look at the three radionuclides of lutetium, gallium, and actinium-225, which we already heard a lot today. And I will tell you, of course, when I speak why of these three, we can ask ourselves how to find the right partner between the theranostic pairing in the first place. And I think we've heard a lot of talks today already about the different pairing of different isotopes, but just briefly, of course, we can pair our radioisotopes either from the same chemical element or from different chemical elements. And naturally, from a chemist's perspective, you would say, okay, if I have the same chemistry, why shouldn't I directly just go for same isotope pairing? And because this is a new approach, and I would like to give some thoughts to instill the discussion on this. So, when we ask ourselves, when we want to do targeting with radiopharmaceuticals for imaging, for diagnostics, we want to have a high contrast, considerably fast uptake. But if we want to do therapy, what we rather want to focus on is better to have a high and maximum accumulation and retention within the tumor to deposit as much dose as possible for the efficacy of the treatment. Now, when we now look at the pharmacokinetics between the two different categories of imaging and treatment, as I said already, we have two different, let's say, kinetics at work. So if we have a molecule with exactly the same properties, we want them actually to have different properties for the dedicated purpose and optimized purpose we want to have. Also, another point to discuss and to always consider, if we're doing an imaging and radio labeling, we usually use a different mass of the precursor, the biomolecule, than we sometimes do for the treatment. So we cannot necessarily assume that the pharmacokinetics are exactly the same if we use more or less, for example, PSMA or dotatate. And of course, with that in mind, we also have to ask ourselves, can we then actually achieve a comparable molar activity of the radiopharmaceutical we actually administer? And this also is coupled to the production of the radioisotope and its specific activity. So, and last but not least, and I think we heard this in the second talk today already, that the availability is a critical issue, because we want to ensure, of course, when we build a theranostic platform, that we can supply the patient not only with one component, but with both to have and use that potential. So, just concluding that on this regard, just because we have two isotopes of the same element, it does not necessarily mean that they are the ideal pairing It can mean that, but only if all the criteria are met, and this also has to be considered. So maybe to look a little bit again into the pairing of gallium and lutetium. I mean, we've heard it today on several occasions, so I can keep myself as brief as possible. With the Netter and the Vision trial, and now even PSMA4, of course, creeping up, we've seen that although this is a isotope pairing of different elements, this diagnostic pairing works pretty well. And this has a few reasons, which I would like to show when we look at gallium-68 and lutetium-177 side by side. So we all know, of course, that gallium-68 is perfectly established as a PET diagnostic agent or radionuclide already. But to highlight this specifically, we can see that for both radioisotopes, the production and availability is very abundant so far. With gallium, whether it comes via generator or even via cyclotron production, we can establish almost a routinely supply. And as well for lutetium-177, I think besides iodine-131, we can safely say that this is the most abundant therapeutic radionuclide today and used in nuclear medicine. Now, another point which highlights, of course, the two of them as a theranostic pairing is that their chemistry is very similar. While both, of course, have their optimized chelator systems like, let's say, DATA5M for gallium or NOTA, and also DOTAGA for lutetium, you can share common ligands or chelators for radiolabeling both, so you can still use a theranostic molecule and platform for that purpose. And what makes the pairing so well is, of course, that since both have a very stable and routine and abundant supply, only then we can really ensure and do these big trials like Netter-1, Vision, and now PSMA4, because we have the supply. And with this, I would basically give the example for lutetium. I have a few examples, of course, from my own company, but this accounts to each and every manufacturer worldwide right now. All the criteria need to be met. One criteria is, of course, we have to look at the actual first off production. In the case of lutetium, of course, the lutetium NCA production, you need the ytterbium-176 enriched target. This is, of course, not a very abundant resource, so it's expensive, it's hard to come by, and so it's very important that for this process it was also developed to recycle the target material. Only by this you can actually increase the stockpiles much faster and much more than if you just have to basically waste away the target material. And of course, this is something that we should always aim for when we do radionuclide production, not only for lutetium. Next up, we have to have the irradiation facilities. In the example of lutetium, these are not only research reactors by now, but recently, of course, also commercial reactors have been utilized for this purpose, successfully so far. So we can say that this also takes another step towards resilience of supply, because the more reactors and irradiation facilities we do have, and we all know this, research reactors, they have maintenance, they have other experiments running, they are not made to run 24/7, 360 days a year. And I think making a step towards commercializing reactors in addition to research reactors, we can stabilize the supply while still, of course, increase the activity we can deliver at the same time. Now, other criteria is once we have, of course, an irradiation basically established, a network, we need to process the material, because when you, and in this case we have to, for example, separate the lutetium from the target in order to recycle the target material again. So basically all these processes need facilities. And with just one facility, and this we've seen also for technetium generators in the past, or just two facilities globally, if there's a technical issue, we run into a supply shortage right away. So even if the network and everything before that is set, if we do not have a robust facilities and a multitude of industrial facilities for processing the radionuclide and delivering it globally, we always run the risk that problems, or even like things like a corona pandemic, which nobody could have anticipated, can lead to supply shortages and therefore impact the nuclear medicine treatment negatively. And while speaking of delivering, last but also here, not least, our nuclear medicine is so dependent on very good logistics. There is never time for customs to say this package needs one more day of processing. And we cannot stretch and stress, of course, how streamlined this whole process needs to be. And I think, again, here, it is basically a linear system. So even if this last step, there is a problem, then all the good work that has been put into the system beforehand is not worth if the package or the dose is not delivered in time. Now, oh, okay, good. Maybe then I have to quickly jump basically to actinium quickly, as much as possible. So we've seen basically these studies today already, and just why I think that actinium will be the third part in this theranostic pairing is that from the irradiation point of view or the decay point of view, you of course have a different type of decay, and not only I mean by linear energy transfer, meaning you can deposit much more energy and sometimes see better efficacy results, but also because you have a more precise irradiation. Now, why I think that alpha therapy will not replace beta therapy at all is that when we have large or very heterogeneous tumors, the uptake is not homogeneous as well. So what we need is radioisotopes that will still be able to irradiate more or less homogeneously the tumor. And for this purpose, I think a kind of a complementary synergy between actinium and lutetium will be necessary in the future. So, and just quickly highlighting that we need the same, let's say, expertise and technical advances on actinium that we've seen for the lutetium industry already. Currently, we have 4 different manufacturing methods for actinium. The first one is the thorium cows that we all know. It's a very limited supply because we would have to wait for the uranium-233 to decay, which is just a few megabecquerels annually, globally. So this will never solve our supply solution for nuclear medicine. Instead, and I would like to focus on the fourth method just briefly, because the second one bears the risk of producing actinium-227 as a byproduct. The third one has not been tested to meet the scale yet. So let's look into the proton irradiation, because it has been a process that was established already years ago in cooperations between the Technical University of Munich and Actinium Pharmaceuticals. And this irradiation method will yield a product, or basically an actinium-225 solution where you do not have any actinium-227 with a 22-year half-life. You have good activities available and possible to scale even further. And even if there's a small chance of a PN and P3N reaction of actinium-224 and actinium-226, the usual time it takes from the irradiation to when the dose really sits at the, let's say, clinic is mostly about 10 days if you take processing, transport, and also cool down of the target into consideration. So even then, the actinium-226 levels will be very, very low, and you will have a radionuclidic purity of more than 99%, of course. So maybe to conclude also in this regard, although this was very brief, I hope you could follow me. I think that actinium-225 is positioned with the current methods to become basically the next radionuclide abundantly available for treatment, as much as we've seen it with lutetium in the last 10 years. And I think all the criteria are currently met for this purpose. So in full conclusion then, and I hope that's fine that I still give that, I think we can say that the future of theranostic therapy is not only dependent on a pairing of 1 or 2 or like same chemical isotopes, which doesn't mean that we shouldn't be looking further, but I would still say that we basically concentrate and prioritize to use the radionuclides we can already abundantly have today to provide the nuclear medicine. And of course, I think with all the clinical trials about lutetium and gallium, we've already said enough. So I'm happy to take questions.